department if I could. I thought Ben Johnson highlighted it well when he said we need to have an outline for what our plan is. We heard from Maya Altman about how the legislature needs to put its policy goals out front, and will just wear on my sleeve how much I've tried to have us as a legislature prioritize and incentivize preventative care and drive towards quality. That I'd like to hear from the department if I could. If we set aside the variations of cost of living that we have in our state, generally, are our managed care rates set with an eye towards incentivizing preventative care and driving for quality?
So in today's rate setting, we utilize the cost information from the plans themselves. So the base of rate setting is based on the actual cost that the plans have in providing care. As I mentioned, we have included several directed payments where we're adding incentive payments and additional payments around quality. And additionally, we are looking at how we can more effectively include and incorporate and embed those quality factors and access considerations into our rate setting more broadly, and we will be continuing to work with our plan partners as we move forward in that adjustment. But today, the rates are set based on the actual cost that the plans have for setting and providing services.
I understand the answer and the response from the department. I would just, again, elevate the concerns that many of us have in the legislature to make sure that we're getting the quality that we should be for the investments that we're making. And we just want to make sure that that was heard here today. With that, I will thank very much Panel 2, and we will move on to Panel 3.
Thank you very much, Dr. Rambula, and thank you to our witnesses. We'll go ahead and move on to Panel 3. Okay, our witnesses for this panel, Anastasia Dodson, the Associate Director for Policy, or J.C. Cooper, someone from the Department of Healthcare Services, I believe. Ned Resnikoff, Fiscal and Policy Analyst for the Legislative Analyst's Office. Jack Daly, the Director of Policy and Training and Coordinator, the Health Consumer Alliance at Legal Aid Society of San Diego County. It's a lot to put on a business card. Maya Altman, Chief Executive Officer of the Health Plan of San Mateo. Eve Gelb, a Senior Vice President and Member in Community Health, SCAN Health Plan. So we'll go ahead and start with the administration.
Thank you. So I'm going to turn it over to Anastasia Dodson, who will present on behalf of the department today.
Thank you. And the topic here is the sunset of Cal MediConnect and requirement for aligned dual eligible special needs plans, or DSNPs.
Good morning, Mr. Chair. This is Anastasia Dodson from the California Department of Healthcare Services. Yes, we have very pleased to be working on this aspect of the CalAIM initiative, the transition of the Coordinated Care Initiative and Cal MediConnect. We have a number of lessons learned through the Coordinated Care Initiative that are woven throughout the CalAIM proposal. We know that dual eligible beneficiaries benefit from integrated and coordinated care, which is why we're proposing to extend Medicare and Medi-Cal aligned enrollment to all counties in the state. Currently, as you know, in CCI, Coordinated Care Initiative counties, that's where we have Cal MediConnect, but we want to expand this model statewide to have aligned enrollment. The risk assessment process has been very helpful, and lessons learned that we are going to apply in CalAIM for the population health management strategy for CalAIM, and that risk assessment process was developed with stakeholders for Cal MediConnect and CCI. In CCI, we really saw the value of Medi-Cal managed care plan engagement with providers, counties, and community partners on IHSS and a number of other programs to better coordinate that full range of services and reduce beneficiary and family caregiver confusion. In CalAIM, we're going to be incorporating those partnerships throughout the enhanced care management and in lieu of services benefits. Another aspect of CCI and CalMediConnect we're very proud of is the Dementia CalMediConnect project, which provides consultation to health plans and training for care managers and family caregivers in partnership with the Alzheimer's Association. DHCS will be incorporating this successful model into CalAIM for both dual eligible and Medi-Cal only beneficiaries. Also in CCI, the Coordinated Care Initiative, we found that health plans can really play a key role in supporting beneficiary transitions from institutional care into the community. CalMediConnect plans now use the flexibility of care plan options and the financial alignment of Medi-Cal and Medicare in CalMediConnect to invest in community transitions and help members transition from institutional care into the community and successfully stay in the community. These lessons that we learned were really instrumental in helping to develop the enhanced care management, and particularly in identifying the populations in need of greater care management and a number of the in lieu of services, including community transitions and home modifications. CCI CalMediConnect has a long history now, so we're definitely using those lessons learned. The lessons learned also helped us support the statewide carve-in of long-term care into managed care. So just to share a couple of data points, the 2018 SCAN Foundation report that assessed the experiences of dually eligible beneficiaries in CalMediConnect found that 94% of CalMediConnect beneficiaries reported that they were very or at least somewhat satisfied with their benefits. And this was highest among the CalMediConnect beneficiaries compared to those who opted out or those in non-CCI counties. There has been a significant reduction in emergency department use, according to that SCAN report. And in 2017, 87% of CalMediConnect beneficiaries rated their quality of care as either excellent or good, which is an increase from 84% in 2016. So we're proud of that. And so the next question, related point, was about for dual eligible special needs plans, or DSNPs, on the Medicare side. Just to make sure everyone is aware, that's a voluntary opt-in enrollment by dual eligible beneficiaries. So there will not be passive enrollment into DSNPs, so that individuals who are enrolled in fee-for-service and most Medicare Advantage products, they will not have passive enrollment. However, we are at the end of 2022 when we transition individuals who are currently enrolled in CalMediConnect into an aligned DSNP and Medi-Cal managed care plan. We will have a crosswalked enrollment process, and we are discussing this fully with stakeholders at a stakeholder work group series that we've started. So we're working collaboratively to make sure that transition goes smoothly. One other piece, a technical piece, but flagging that CMS is not renewing contracts for Medicare Advantage DSNP lookalike plans that serve dual eligibles but don't offer the same benefits. So there will be a transition process for those members into a DSNP product with substantially a similar provider network. So we will have some structured transitions of certain beneficiaries into better coordinated managed care structure. And then lastly, when a Medi-Cal only beneficiary, someone who's not yet eligible for Medicare, when they gain Medicare eligibility through age or disability, then the DSNP line of business that's offered by the Medi-Cal plan that they're in, that plan will transition them into the aligned DSNP. So again, we're going to be talking in great detail with stakeholders about all of these processes, and over the coming 18 months or so before the transition occurs in 2023. So, but in all cases, dual eligible beneficiaries continue to have the right to choose Medicare fee-for-service or Medicare Advantage plans. That's a fundamental piece in CalAIM. There was a question about DSNP viability, even if they have limited enrollment in a particular county. Those plans often cover multiple counties. So there are currently DSNPs operating in 36 of California's 58 counties, and health plans have made the decision to operate DSNPs with fewer than 1,000 members in a county. So it is viable, and we're glad to continue to have conversations with plans and advocates about this, but it's a viable model. And for subdelegation, the DSNP aligned enrollment policy would be the same for the Medi-Cal Prime or non-delegated plans. So what that means is a beneficiary that's enrolled in a DSNP for Medicare, if that DSNP is a delegated plan, then the Medi-Cal side, where there's a delegated plan on the Medi-Cal side, that would match. So we will make sure that the beneficiary benefits from the coordinated care from having the same organization manage their Medi-Cal and Medicare benefits. And again, we're talking through a lot of the details in our stakeholder work group. Finally, there's a question around the CalMedi Connect Ombudsman and additional funding for HICAP. So we anticipate having federal funding for both of those programs through early 2023. And then in the upcoming budget development process for 2022-23, which is has not started yet, that's, we'll process internally within the administration next fall, and then release the governor's budget next January for 2022-23. So right now we're just focused on the pieces of CalAIM that we need to work on with stakeholders, and the budget process for next year, we will do that in due time. So I think that is the extent of the questions.
Well, thank you very much. I think we will have some additional questions for you, but I got to ask this one because I've heard a lot of terminology in my time as chair here. But what is a crosswalk enrollment process? I've never heard that one.
Okay, sure. So what we will do is in sort of an automated way, make sure that if someone is enrolled in CalMedi Connect for a particular health plan right now, then in preparation for January 2023, we will do we will work with the health plans and CMS on an automated process so that they stay in that same health plan, but they will split with for their Medicare benefits, they will be in a DSNP, and for their Medi-Cal benefits, they will be in a Medi-Cal managed care plan. But both of the DSNP and the Medi-Cal plan will be operated by the same parent organization. And so by having that same organization administer and the benefits for both programs, they can share data internally. They can have the same care coordinator. They can coordinate across providers. But that crosswalk enrollment makes sure that beneficiaries don't need to make an affirmative selection. They will automatically go into a Medi-Cal and a DSNP plan that matches their current CalMedi Connect plan.
Okay, good. Well, thank you. Now I've got something else for my vocabulary that I didn't have before, so much appreciated. We'll go ahead and move on to our next witness, Mr. Resnikoff, Fiscal and Policy Analyst for the Legislative Analyst's Office. Thank you.
Good morning, everyone. This is Ned Resnikoff with LAO. As we describe in our report on CalAIM proposals related to seniors and persons with disabilities, the current landscape of care for seniors and persons with disabilities, SPDs, is highly fragmented. And that's the case both for sort of the landscape of programs such as IHSS and PACE and so on, but also for fragmentation between Medi-Cal and Medicare. So we do think that the DSNP proposal could potentially improve coordination between Medi-Cal and Medicare for the senior population and the dual eligible population. But there are potential trade-offs between the scalability of the DSNP model and the level of coordination and integration that DSNPs would offer. And there's also some questions regarding the level of standardization statewide that would be possible. Now, the trailer bill language from the administration doesn't really specify what specifically would be required of DSNPs. And because the state is going to be setting DSNP contract terms under CalAIM, this could be a possibility. This could be an opportunity for the legislature to think about what sort of terms and what requirements should be imposed on DSNPs. One more comment, which is that it's unclear how viable it is to take DSNPs statewide into every county, and what sort of policy or fiscal incentives would be needed for plans to actually make sure that there's full DSNP coverage in all areas of the state. So that's just something else that the legislature might want to consider. Thank you, and happy to take any questions.
Great, thank you very much. Appreciate that. We may have a question for you as we move through the rest of the panel. So we'll move on to Jack Daly, the Director of Policy and Training and Coordinator for the Health Consumer Alliance at the Legal Aid Society of San Diego County.
Thank you very much. I agree that is a mouthful. My business card is busier, and I actually left off one of my titles. So
that's why you have a backside of the card. So you know.
Exactly. So thank you for having us. We are the lead agency on the CalMeta Connect Ombudsman program. And just for reference, the CalMeta Connect Ombudsman program provides local independent advocacy to CMC members and CMC eligible duals in each of the 7 CCI counties. So we appreciate the opportunity to come and provide feedback. All of our perspectives are really informed by years of helping dual eligible consumers maintain coverage and access needed care in CCI counties. And so in terms of the lessons learned, we certainly have been happy to offer and provide those lessons and insights. We certainly applaud and support the department's goals to provide dual eligible Californians with integrated, patient-centered, and coordinated care, and really do appreciate their efforts to engage stakeholders in the planning process. As Anastasia mentioned, that they have a specific dual integration MLTSS work group, which we've been involved actively, and we really do appreciate that opportunity. The scale and the scope and the complexity of the proposal really does have to be appreciated, in particular in terms of the populations that we're talking about. Most, if not all, of the 1.4 million dual eligibles in California will be impacted in some way by this proposal. So it bears a value in kind of looking at this population a little more carefully. This population is culturally and linguistically diverse, has very complex care needs. They have multiple care providers, specialists. They are twice as likely to have behavioral health conditions. In the context of the public health emergency, dual eligibles, especially those from Black, Latinx, and API communities, are being diagnosed, hospitalized, and are dying due to COVID-19 at disproportionate rates. So this is a complex population. And so in the context of the proposed transition, we really emphasize the value and the importance of setting as a priority, minimizing disruptions to care for dual eligibles. The process of getting to where we want them to be in the DSNP plan is fraught with risks and challenges, and so we're certainly happy to be on board and partnering with the state for the planning process of that, but want to highlight some of those risks. This is a statewide transition process, and hundreds of thousands of dual eligibles will now find themselves in Medi-Cal managed care for the first time. And just by comparison, when we implemented the CCI in 2014, that implementation was really only a fraction of the scale of this transition proposal. So during that 2014 implementation, we in the Ombudsman Office and in other advocates in the community experienced enormous confusion and fear amongst the dual eligibles that we were interacting with as they were interacting with this process and attempting to access care. There were during the transition process, there was concern about coverage and disruptions to care, and that in many instances led to a disruption or a lack of buy-in rather to the program ultimately. we received probably thousands of calls per month during that first year from frustrated and confused patients, many of whom could not access services that they needed, had providers cancel appointments for them or refuse to see them due to the change of their coverage. So, despite the best of intentions when that process rolled out, there's just were a number of systemic challenges and impacts to consumers. I mean, we helped consumers that had their coverage disrupted during cancer treatments. We helped folks who had pre-approved and authorized surgeries that were canceled due to the days in advance of the surgery due to change of coverage, and folks facing difficulties accessing needed medications. So really, the efforts that the planning group is making towards avoiding those disruptions in this transition process are really of utmost importance. Post-transition, we really encourage a rigorous oversight role for the department, and exacting accountability and evaluation over this process is also another priority. Oversight and accountability of plans, especially DSNPs, should include improved data reporting metrics that measure whether Medi-Cal and DSNP plans are connecting duals to needed long-term services and supports, and doing so equitably. LTSS utilization, as Ned just referenced, is a very complex and fragmented system. And so the coordination of that LTSS utilization, the referrals, even the expenditures, including expenditures on home and community-based services, really must be monitored and tracked very closely. Additionally, earlier reference to broad-based demographics data collection, and I think that's really important. But not only just collecting information, but collecting and synthesizing that information with utilization data, so that we can really track the intersectionality between disparities of how people access care, and then really set as benchmarks for plans to help reduce those efforts. Relatedly, the planning implementation process, as well as the care delivery process, must prioritize reducing these disparities and be equity centered. During the CCI demonstration process, there were a number of disparities that came to bear in terms of who participated in the CalMed Connect program, who opted out. In part, there were certainly efforts to engage providers and related community or communities of color and LEP communities. However, that wasn't always successful, and so we saw huge mass opt-outs of distinct communities of color and limited English proficient patients that really could have benefited from these wonderful services. Language access barriers and limitations amongst providers and some plans present some further challenges to LEP populations. And I think we've seen COVID only exacerbate these inequities. So we really want to put forward equity as a priority to be built into every aspect of this transition planning. And we want to emphasize providing sufficient time for consumer and provider education and engagement. That was a key issue with the prior implementation. Notice and materials testing is always important, of course, especially reaching out to such a diverse population. And inclusion of terms and conditions and contract provisions that establish benchmarks and targets for reducing disparities. And I think I mentioned that previously. Finally, we feel our role in this process has been really important. We need to support dual eligibles, help them understand and navigate these transitions. So continuing our comprehensive ombudsman services program, we feel, is absolutely critical, not only through the transition, which really is starting in 2023 for many dual eligibles, but carrying through to the end goal in 2025 and beyond, to provide supports to dual eligibles that need assistance to address individual barriers, and then we can then turn around and flag those for the state and help address those barriers. So I appreciate the opportunity to present today. If folks have any questions, I'd be happy to answer those. Thank you.
Great, thank you very much. Appreciate that, and we may come back to you with questions. So our next witness is Maya Altman, the Chief Executive Officer for the Health Plan of San Mateo.
Hello again. I'm glad I'm following Mr. Daly's testimony, because I think he really brought things front and center, putting front and center the 1.4 million Californians who are eligible for both Medicare and Medi-Cal. These folks are poorly served in current systems, and they are among the highest need populations. The lack of good options and good care for dual eligibles is really an equity issue, as he explained. And just to put a pin in some of his points, I have a couple of really telling statistics. As of November 2020, 40% of the Medicare beneficiaries, this is nationwide, who died of COVID-19 were dual eligibles. Nationwide, the rate of hospitalization due to COVID is 3 times higher for dual eligibles compared to the general Medicare population. And as he said, the dual eligibles are poorer, they're more likely to be people of color, they have more health issues and challenges, and they have to deal with more psychosocial needs than the general Medicare population. I served on the Master Plan for Aging Stakeholder Advisory Committee, and the needs of dual eligibles was a major focus for us. One of our recommendations was calling for a plan, and we recognize this is ambitious, it's not going to happen quickly, but really a long-term plan to guarantee that there will be integrated options in every part of the state for dual eligibles. These could be PACE programs, something like CalMed Connect, but better, or truly integrated dual eligible special needs plans. This recommendation also speaks to the geographic inequities in the state. Many rural parts of the state have so little available in terms of options for ranges from LTSS options to options for integrated care. But even in urban areas, there are major problems. And that's why it's really critical, and why I support the state's requirement that the DSNPs really be aligned, as they call it. I'd argue that there's too much choice on the Medicare side. I'm 65, and I've been bombarded with mailings about Medicare Advantage plans. In Los Angeles, I understand there are more than 90 Medicare Advantage options for people. Now, all these plans, these Medicare Advantage plans, include duals in their marketing, whether intentionally or not. And at times, it's very misleading and confusing for dual members, for dual beneficiaries. So what we really need, I think, is a curated choice, and the line DSNPs would accomplish that. In the end, there may be fewer choices for dual eligibles, but it would be real meaningful choice. So dual eligibles, and again, under this proposal, they can stay in fee-for-service. There's no proposal for passive enrollment or making people enroll in DSNPs. They can stay in fee-for-service, or they would have at least one truly integrated Medicare Medicaid plan if that's what the enrollee wants. Another key issue, and others have touched on this, is what is true integration? True integration goes beyond just integrating Medicare and Medi-Cal benefits, but that is critically important. It means integrating or close coordination of health with long-term services and supports, with behavioral health services, and other critical services such as housing and food availability. The state should ensure that the aligned DSNPs are as highly integrated as possible. So just one example, long-term care. At the very least, any aligned DSNP has to take responsibility for both Medicare and Medicaid funded long-term care. If not, the DSNPs will have no incentive to help people avoid long-term nursing home stays. So for example, under CalMed Connect, our plan, Health Plan of San Mateo, has helped hundreds of people, hundreds of our members move out of nursing homes. And that's only possible because we have responsibility for long-term care. And finally, similar to the good doctor at the last panel, I wanted to point out on the ground the real world impact that integrated Medicare Medi-Cal care can have. So to date, 55% of HPSM's eligible CalMed Connect duals have been vaccinated. We think that's good progress, but it's still lower than the 75% vaccination rate for the 65 plus general population in the county overall. We think it's progress. It's good progress because we know that the dual eligibles face technology issues, they face transportation issues, and other challenges. And the reason we can make this kind of progress is because these members know and trust our plan. We've engaged with them over many years, and we know how to work with them. So one specific example is early on, we immediately engaged a trusted organization that we subcontract with that combats social isolation among our duals, especially during the pandemic. When the vaccines first became available, this organization called Wider Circle was able to immediately engage more than 500 of our Spanish-speaking only duals and ensure they got to vaccination appointments, which was no easy task. So, integrated care will make a huge difference in people's lives. And I thank you for the opportunity to testify and available for any questions.
Thank you very much. We'll take you up on that probably after the panel goes through here. So thank you. Our final member of the panel is Eve Gelb, a Senior Vice President, Member in Community Health, SCAN Health Plan.
Yes, thank you very much for the opportunity to present, and I'm going to follow up right on what Maya said about fully integrated models, because that's exactly what we've been able to provide. So I am the Senior VP of Member and Community Health for SCAN Health Plan. And perhaps a new piece of vocabulary, we are what is called a fully integrated dually eligible special needs plan. So a FIDE SNP. We happen to be the only one in the state of California, but I fully agree with what Maya was saying and with what others were saying about fully integrated options. And we've been around. Long Beach, California is where we started. We were founded by a diverse group of seniors who their real focus was how to keep people out of nursing homes. And that's really been the foundation of our organization. We now serve about 220,000 Medicare beneficiaries in 11 counties in California. As a Medicare Advantage plan, an MAPD plan, but about 15,000 of our beneficiaries are dually eligible and dually enrolled in our FIDE SNP in this fully integrated model. And it brings together the best of both worlds, as the physician earlier was speaking to, both on the Medicare and the Medi-Cal side. A multiple set of quality metrics. We are 4.5 stars. We have been for many, many years. And that's, all of our Medi-Cal beneficiaries get treated equitably, have good care, and have 4.5 star quality plan available to them. And to the point that the physician was making earlier, one of the reasons is because of our strong provider network. So providers just need to provide care. We do all the rest in the FIDE SNP, which is the wraparound services, including the integrated long-term services and supports. And what that's been able to deliver is less than 1% of our dually eligible beneficiaries are enrolled in a long-term care facility. And those numbers that Maya was mentioning related to COVID, a lot of that has to do with folks who were living in long-term care facilities. And our raison d'etre, our reason for being is to keep seniors living healthy and independently in the community. And you have to do that by fully integrating their whole person needs, which is why I love the whole person model. I love what the state is doing with CalAIM, what DHCS is trying to do, and the many stakeholders that they're bringing together. So one lesson we did learn from the Coordinated Care Initiative was that providers are key stakeholders and they influence beneficiary choice. And so we have to work with a product that has strong partnership with those providers and enables them to, as the doctor said, deliver care regardless of the beneficiary's coverage. They just know that they need to provide the high quality care. Another lesson we learned is that beneficiary choice is important. So to the point that the Legal Aid Society was making, there was a lot of beneficiary churn where folks were disenrolling from their assigned plans. We saw amazing stability in our membership through this transition because we are fully integrated, because we provide good services, but also because of the beneficiary choice where they had that integrated option that Maya was talking about in the counties we serve. And this integrated option is in Riverside, San Bernardino, and Los Angeles counties. With respect to the LTSS subdelegation that Anastasia was talking about, so our model has been fully integrated, and not only has it allowed us to achieve those low institutionalization rates that I talked about, the less than 1%, but we've also been able to demonstrate lower acute utilization, lower readmission. And so what this model does is it creates savings for both Medi-Cal as well as Medicare. So not only is it a model that produces high quality outcomes, but it also reduces cost. So in short, our recommendation for CalAIM is, given that the FIDE SNP is a model that really enables population health approach, a whole person model that allows us to look at our population, the segments in our population, the race, the linguistic, the SOGI needs of our population, and deliver care that's going to reduce inequities. It is also fully integrated with respect to all of the needs, not just the medical needs, but the social needs, the social supports, including our beneficiaries experiencing homelessness. And I think that that a model like this, which has both CMS and DHCS oversight, provides the greatest level of beneficiary protection. So we would encourage the department to allow the growth of FIDE SNPs and to allow FIDE SNPs to fully participate. It's a model that serves, about 150,000 beneficiaries across the country, but in California, only 15,000. So really an opportunity to grow a model that has been doing enhanced care management and in lieu of services throughout our history. And so we're encouraging the growth of that model. To Maya's point, the growth of fully integrated options, whether they be PACE, FIDE SNP, or something else, in all counties for the beneficiaries of the state, and to allow these models to formally offer and participate in lieu of services, just consistent with the rest of the Medi-Cal managed care plans. I thank you for the opportunity to speak and be happy to take questions.
Thank you very much. We'll bring it back to the committee for questions. Dr. Amila. So I have a couple. First of all, and this is we're going to ask for the administration to hopefully answer for us. This is a complex area, multiple payers, multiple programs. And my read of the proposed trailer bill is that we are now just requiring institutional long-term care to be a part of the benefit plan, and we're requiring an aligned DSNP and Medi-Cal managed care plan. But we're not taking action on the current home and community-based services programs. Is that correct? Or does this proposal deal with home and community-based service waiver programs?
So this is J.C. Cooper. What I would say is the biggest piece that I think is the opportunity is the expansion of the in lieu of services. Many of the things that we have seen done in both the CCI, CMC plans is really around those transitional services, things like providing medically tailored meals, home modifications. So the in lieu of services would be available for all partial dual and dual eligible individuals in the DSNP proposal that is before you for consideration. And so they would have access to growing those various home and community-based or LTSS services in the Medi-Cal managed care plans. And then as we grow and have additional capacity statewide, the department would consider what we officially carve in regards to benefits to eventually get to long-term services and supports by 2027 is the goal for kind of building in infrastructure over time.
So as you begin to flesh that out, there would be conversations. So we kind of know as we're going along, rather than boom, here it is.
Yeah, because we're going to need to build capacity. I mean, it's one of the biggest opportunities right now, in our opinion, is as we're building in these in lieu of services, really expanding access to these home and community-based services, transitional services that we really think will really serve our dual populations very well. And so we would fully engage in regards to any transitions of adding new benefits to the Medi-Cal managed care responsibility, as well as what that means for our 1915C waivers moving forward as well. very critical. A lot of the providers who provide services in our 1915C waivers those are the ones that we're working with very closely to figure out both the in lieu of services eligibility criteria, learnings from those programs, and connecting those resources to our managed care plan so they can leverage those as in lieu of services to increase that capacity. So yes, the department fully committed to engaging with the legislature in regards to those proposed changes in the future.
Okay. While you're still there, so the LAO has a recommendation about setting a minimum standard of care for integration and coordination of DSNPs with Medi-Cal managed care plans. What's your reaction to this recommendation?
I will pass this one off to Anastasia. I know she's been doing a lot of thinking and conversations with members on this one. And so, Anastasia, do you want to respond to that question?
Sure. Yes. Hope you can hear me. There is actually already a minimum set of requirements in the current DSNP contract known as the SMAC, another word for the day. Sorry. Anyway, but there are already minimum standards and requirements for integration and coordination that we expect the DSNPs to comply with. And then we are actually working right now on updating, improving those requirements for 2022. And then we will have a much bigger conversation in our stakeholder group for 2023 to have stronger requirements, adopting many of the integration pieces that we have from CalMedi Connect, and then incorporating all of the elements of CalAIM that are also being worked on across many areas into the SMAC contract.
Great, thank you. You all ought to have a glossary for all the little phrases you have. So I will tell you, and this is a true story, I for a while thought that Mr. Mibb was a real person until I understood what Mr. Mibb really meant a long time ago. So just throwing that out there, I didn't ask, and I just assumed it was a real person. Anyway, that was before I was in the legislature. So thank you. Appreciate everybody on this panel. We'll go ahead and move on to the fourth panel. Dr. Arambula.
Thank you very much, Mr. Chair. We will now move on to panel 4 on the proposal to require jails and county juvenile facilities to process Medi-Cal applications at the time of their release. We will have 5 speakers on this panel, including J.C. Cooper, Ned Resnikoff, Kathy Senderling McDonald, Dave Putnam, and Catherine Cohen. If we can please begin with J.C. Cooper.
1 second. As I'm rolling this up, one thing I would just flag is that we actually do have an acronym book at DHCS when you start here, and it is 65 pages long and I think growing. So definitely something we need to work on.
Well, you can send us a copy. We'd love to have it.
Except for it gets outdated about within a month because of how many new acronyms